selector for the week.
Hey everyone, I'm Chris Singh. I'm one of the PGY3s in the EM program. Today I'm going to be talking about ED quality metrics and physician efficiency.
On your screen.
So I'd like to thank the Admin and Policy Committee, Drs. Brewster, Meta, Chen, and Bill for helping me prepare this topic. For this presentation, I also made a survey for our alumni listserv. I'd like to thank Dr. Willis for sending that out for me, and the 9 alumni who responded to it. That was pretty good. For this presentation, I'm going to be going over where do metrics come from and why do we measure them? How do quality metrics affect the practice of emergency medicine? And how can I personally see, or how each of us can see more patients more efficiently? So quality metrics were really formalized with the establishment of CMS in 1965. As most of you know, CMS administers Medicare and Medicaid, and they were the first public health insurance plans provided by the federal government. And a lot of the debate surrounding the establishment of CMS had to do with how much it was going to cost the American taxpayer. And sure enough, within the first 3 years of its implementation, the actual costs of Medicare and Medicaid outpaced the projected costs by 30%. So it was already costing more than people expected. So in 1972, CMS established utilization review committees, which basically required participating physicians and hospitals to basically show that they were providing services appropriately, providing appropriate services and not over or underutilizing certain ones. So these committees, they just basically just reviewed the reports, but they didn't really implement any corrective actions. So in 1983, CMS started professional review organizations, which also had the ability to implement corrective strategies. And these organizations were like groups of physicians at a local level who would review cases on a case-by-case basis. And then in 1990, these were then replaced with quality improvement organizations, which also had the ability to implement financial incentives and penalties for compliance or lack thereof with these standards. So more recently, there's been a lot more talk around quality and healthcare value. In 2006, CMS developed the Physician Quality and Reporting System, or the PQRS, which allowed individual physicians to gather and submit data on certain quality metrics, which they could then receive incentive payments for on their Medicare reimbursements. And then, of course, in 2010, the Affordable Care Act was passed, and this included several mandates to improve the value and quality of care in the US in general. More specifically, in 2012, the Hospital Value-Based Purchasing Program was implemented, and in 2015, the Medicare Access and CHIP Reauthorization Act, or MACRA, was passed. I'll go into a little more detail about these two pieces of legislation. So starting off with the, so these two programs, I think, are the ones that are going to affect our practice the most going forward. So the first one, the Hospital Value-Based Purchasing Program. In this program, basically hospitals monitor different quality metrics and then submit them to CMS, and they can receive incentive payments based on their compliance with those metrics. And the thing I want to emphasize here is that, you know, these metrics are ultimately based on what we as individual physicians do, even though it's the hospital that's receiving incentive payments. So in 2020, there are several different metrics split into outpatient and inpatient metrics, both of which contain metrics that are relevant to emergency medicine. So on the outpatient side, there are things like median time to EKG, time from arrival to departure to discharge patients, rates of left without being seen, and then the transfer to another facility for ACI in patients with MI if you don't have CAT on site. There are also some metrics that focus on the appropriate testing and treatment of URIs. So appropriate throat swabbing of children with pharyngitis, antibiotic use for otitis externa, and avoidance of antibiotic treatment for adults with bronchitis. On the inpatient side, there are some things that affect us too, including admit decision time to departure time for admitted patients, and then compliance with sepsis bundles. So that's on the hospital level. And, but then there's also the merit incentive-based payment system, which was a part of the MACRA law, which basically looks at individual physicians' compliance with certain quality metrics, and then Medicare gives incentive payments on the physician fee for reimbursements. So under MIPS, physicians, we go about our day-to-day practice, and with the EHR, certain quality metrics are kept track of. These metrics are then basically summarized and compiled by our ER physician groups. In our case, for instance, like the Kings County emergency department. In the future, if you work for a group, it might be a particular CMG that compiles them, and then they submit to CMS for incentive payments on the physician fee. So MIPS has several different components to it. In addition to quality metrics, they also look at resource use and costs, your involvement in quality improvement efforts, as well as promoting the use of EHRs and intercommunication between hospitals and physicians. So I'm going to talk a little bit more about the quality metrics, obviously. So for MIPS, for emergency medicine, some of the metrics focus on the use of radiological studies, so CT scan for minor head trauma, acute sinusitis, and neuroimaging for primary headache. So one thing I thought was interesting, by primary headache, they mean headaches that are not caused by a medical condition or underlying medical condition, but frequently we get the tests or the imaging to determine that it's not. So I'm not really sure exactly how they're going to judge that. Like the hospital program, there are also metrics for appropriate use of antibiotics. One thing I thought was interesting was that they are going to look at the use of amoxicillin versus augmentin for bacterial sinusitis, which seems pretty granular to me. And then another group of metrics I thought was pretty mind-blowing. So they're going to look at ACE inhibitor, ARB, and ARNI therapy for left ventricular systolic dysfunction. And this is specifically for emergency medicine. So they're basically expecting us to, I guess, prescribe outpatient medications for heart failure, which I thought was kind of strange. Another part of the MIPS program, so in addition to your particular physician group submitting the metrics, there are organizations called qualified data registries, which are basically an intermediary between physician groups and CMS. So these data registries, they can work with ER docs and ER groups to come up with their own metrics, get them approved by CMS beforehand, and then basically summarize and submit to CMS for the incentive payments. And obviously the thought behind this was that, this gives physicians a little bit more control in terms of what is actually monitored and tracked. So it's also interesting, the organizations that can become qualified data registries. The one that I think is being talked most about is the Clinical Emergency Data Registry. And so this is the one that was started by ASAP. And it was probably probably the one that a lot of groups are going to be using. But also Vituity, which is a very large contract management group mostly out in the West Coast. They are also starting their own data registry. So they're essentially going to be submitting to themselves and then submitting to CMS, which I thought was interesting. And then there are private companies that are also going to be data registries as well. So I wanted to just briefly mention some of the few metrics that that ACEP has come out with, which I think overall make a little more sense to me, or more familiar to us as ER docs. So avoidance of opiates for more than 3 days in discharge patients, and then tobacco screening for patients with asthma and COPD, compliance with sepsis metrics, including lactate measurement and clearance. And then again, imaging or appropriate imaging. So they have metrics for imaging in kidney stones, x-rays for non-traumatic low back pain, syncope, and pulmonary embolism. So overall, those are metrics that I think are going to be affecting us more in the future and how we're paid. I think a lot of them, there's a lot of question about exactly how it's going to be implemented at this point. A lot of the research I did and the alumni who got back to me mentioned these specific metrics that they are seeing right now, including patients per hour, satisfaction ratings, 72-hour bounce backs, consultation rates, CT utilization, sepsis compliance, and rates of left being seen. One thing, I'm going to be talking more about patients per hour, but one thing I thought was interesting was that a lot of the alumni said they aren't too stressed out about seeing enough patients. The ones that they're more bothered by consistently are the satisfaction ratings and the left without being seen, because oftentimes they don't feel like they can necessarily control those as well. But in terms of patients per hour, most of our alumni say that they see around 2 patients per hour, and some specifically mentioned like that's pretty much the industry standard. So in terms of how to be more efficient in the ER, a lot of our alumni and a lot of articles I saw mentioned just being as decisive as you possibly can. So one of our alumni mentioned that once you step out of the room, you should really have a plan already in place about what you're going to order, and ideally also where they're going to be going after their ER visit. You mentioned think dispositionally, all patients leave the ED through one of 2 doors. They're either admitted or discharged. And so all of our testing and all of our treatments should really be focused on helping us to decide where they're going to go. So it's just as important, if not more important, than the specific diagnosis that they leave with. The other thing that they mentioned was consider admission before results. I don't think this would go over quite as well at our hospital than maybe at other places, although I have seen that done with mixed results or reactions. And then also avoid non-contributory testing that won't really determine their disposition. In terms of workflow, they recommend using checklists that you run through frequently. That's something that I started doing as a 3rd year to keep track of patients better in the room. And then identify potential holdups early. So multiple alumni specifically mentioned urine testing. So it's not just a problem here at Kings County, but at most emergency rooms. So they recommend, giving a urine cup to your patient and letting them know how to properly collect it, and then having it sent as soon as possible. Find your style with documentation. One alum mentioned that he batches his notes in groups of 3, and then for seeing new patients. Others say you really just have to ask different people what they do and find your own style. And one mentioned, whatever you do, just don't do it at home because it'll ruin your life. Minimize consultations. We frequently get consultations to help us with procedures and outpatient management. One alumni mentioned that, you know, if you're able to do these on your own, then you can really speed up patient's disposition. And then communication-wise, let your patient and nurses know about your plan going forward. This can really, it gives them a better sense of what is going to be done in the ER. It gives them a sense of comfort, but also kind of on a practical side, minimizes interruptions from them as you're trying to get work done. So in summary, CMS, which administers Medicare, Medicaid, and CHIPS, is really the driver of quality metrics in the US. The two laws that I think are going to affect us the most are the Hospital Value-Based Purchasing Program and MIPS. And thoughtful practice can improve our efficiency in the ER. Any questions? Yeah.
I feel like there was like some program that was helping account for like the overall health of the patient population you're treating. Like if you have merit-based incentive payment systems, but then your population has a lot of poverty and is real sick, that might not, you know, how can you be compared to other hospitals?
I didn't see that mentioned specifically within MIPS. I know they're part of MACRA. There are a lot of other components to MACRA, specifically like their advanced payment models, which have much more complex rules, but basically I think that's probably where that kicks in, because that one basically allows physicians and hospitals to basically forgo MIPS if they can prove that they are, you know, consistently going under certain reviews on their own.
Did any of the alum kind of mentioned how they got exposed to this? Did they get training, or this just like came on the job where they learned about the metrics?
Most of it came with experience. So just kind of getting to know their particular system better, having more medical knowledge, and just being strategic in terms of how to see patients.
Awesome. Any other questions? Thanks, Chris.